So this lecture is just going to touch really quickly on some basic chest x-ray anatomy. This may be a review for some of you, but I think it's really important to at least watch during your first rotation so that you can feel up to speed when you start looking at chest radiographs. So the anatomy we're going to be focusing on is the Accordion Mediastinum. This is obviously composed of the heart, great vessels, and central airways, which will then give rise to the hilum. We'll then be taking a look at the lungs and the pleura. So let's talk about our central airways. The central airway is composed of the trachea, which divides at the carina into the right mainstem bronchus, which is the more short and vertically oriented mainstem bronchus. And this is why it's said is more frequently aspirated into, because of its very vertically oriented position. We then give off the right upper lobe bronchus, which basically comes off almost immediately from the right mainstem bronchus. And then lastly, the Bronchus Intermedius. The Bronchus Intermedius will then divide into the right middle and right lower lobe airways. These are typically too distal to be seen on a chest radiograph. On the other side, we have our left mainstem bronchus. Our left mainstem bronchus has a much longer and more horizontal course. So the important thing to recognize here are what structures on the lateral view will appear as circles and which structures will appear as elongated vertically oriented tubes. So the two structures that will appear as circles on the lateral radiograph are the right upper lobe bronchus as well as the left mainstem bronchus, because they're facing at you en face. Notice how the right upper lobe bronchus is going to be higher than the left mainstem bronchus. Also note how the Bronchus Intermedius on the lateral view when these structures are overlapping, the Bronchus Intermedius will overlap the orifice or the circle of the left mainstem bronchus. One thing that we're challenged with on frontal radiographs is to find the carina. That's one of the more important things that clinicians want to know in regard to the location of their endotracheal tube. Sometimes we could just see the branching of the airways as we do in this case, in which case at the branch point is the location of the carina. If we're having a hard time finding the carina, what we could do is draw something known as D's line. D's line is where you take a 45-degree angle from the center of the aortic knob and draw that to the spine. The apex of that angle typically corresponds to the location of the carina. Now let's see if we can try to identify the airways in the lateral view. So again, it's important to remember what structures are going to look like vertically oriented tubes and what structures are going to look like circles. That is, which ones can we see en face as circles on the lateral view. So the most superiorly located lucency that we see here, this is going to be the trachea. The trachea is then going to divide into your right mainstem and your left mainstem bronchi. Your right mainstem will then give rise, because it's very short, we're not going to see this well, to your right upper lobe bronchus. Both your right upper lobe bronchus and your left mainstem bronchus are going to appear as circles on the lateral radiograph. Do you remember which one is higher? So the one that's higher is going to be your right upper lobe bronchus. The one that's lower and larger is going to be your left mainstem bronchus. After we give off our right upper lobe bronchus, the only airway that we should be running superior to inferior or vertically oriented should be our Bronchus Intermedius. Remember, our Bronchus Intermedius overlapped the left mainstem orifice on that frontal view, and we can see that here. So this is your Bronchus Intermedius, then dividing into your middle lobe and lower lobe airways. And notice again how that overlaps with the orifice or the en face appearance of your left mainstem bronchus. So let's take a look now at our Accordion Mediastinum and focus more on our heart, which is this egg-shaped structure that's outlined in red here. So we'll focus going from right to left. So the most right lateral structure that we see on the heart is the right atrium, which receives blood both from the SVC and the IVC. This will then dump blood into the right ventricle, which is centrally located in the heart. And notice how the right ventricle does not form a cardiac contour on a normal frontal radiograph. The right ventricle will then give blood into the pulmonary artery, which will circulate in the lungs and return into the heart into the left atrium. The left atrium is the most posteriorly located structure in the heart, and it's going to be in red because it's receiving oxygenated blood. And typically the left atrium is not going to be contour forming, with the exception of this little appendage that sticks out here known as the left atrial appendage. So that portion of it will be contour forming. The left atrium then will dump blood into the left ventricle via the mitral valve. Your left ventricle forms the majority of your left heart border. The left ventricle will then pump blood into the ascending aorta. How do these look on the lateral view? So on the lateral view, most anteriorly, the most anterior structure in the heart to remember is the right ventricle. The right ventricle is the most anterior structure in the heart. Behind the right ventricle and forming the inferior and posterior aspect of the heart is the left ventricle, followed by the most posterior and superior aspect of the heart, which is the left atrium. Notice how the only structure on the lateral view that is not contour forming is our right atrium, and that overlaps the left ventricle. So the only structure that's not contour forming in the frontal is the right ventricle. The only non-contour forming chamber on the lateral view is the right atrium. So what about our major vascular structures? So the first one that we're going to talk about is the ascending aorta. So the ascending aorta again comes off the left ventricle, and then we'll go from right to left. When it's going from right to left, notice how its right lateral aspect actually will form a cardiomediastinal contour. That bulge that is sticking out to the right actually forms a cardiomediastinal contour. This represents the ascending aorta swinging and going from right to left. The aorta then takes an anterior to posterior course. Because it's anterior to posterior, it's going to look like an en face structure or a circle on a frontal radiograph. This is what we call the aortic knob. And then the aorta is actually going to descend posteriorly in the posterior mediastinum, and we can see that on the frontal radiograph. Notice how there's a double density adjacent to the spine there, and that's going to be the descending aorta. And here again is our representation of that on a schematic. So how does this look on a lateral view? So your ascending aorta is going to be anteriorly located, and then go from anterior to posterior, from right to left, and then descend posteriorly. So here's your ascending aorta, followed by the more transverse or horizontally oriented segment, the aortic arch, and then finally your descending aorta. So let's now talk about our pulmonary arteries. So the main pulmonary artery has a kind of funny Y-shaped course here. It basically comes directly off the right ventricle and then goes straight up and then divides into the right and left main pulmonary arteries. So here's your left main. Your left main pulmonary artery has an important course to remember. It goes over your left main stem bronchus. That is that it comes up and goes over posterior to your left main stem bronchus. Another way of saying this is that your left main stem bronchus is hip arterial, that is below the artery. So left main stem bronchus is hip arterial to the left main pulmonary artery, which goes over and eventually behind the left main stem bronchus. That's very important anatomy for you to know. Whereas the right main pulmonary artery, we could actually see that it's below the right main stem bronchus. So the right main pulmonary artery sits in front of and below the right main stem bronchus. Therefore, the right main stem bronchus is said to be eparterial, that is above or at the same level as the right main pulmonary artery. It's important to remember that anatomy, this comes up when you have heterotaxy syndromes and double left-sidedness or double right-sidedness. So one way I remember this is that, for one, hips are located on the lower half of your body. So hip arterial basically means that the airway is below the artery. So what side is that? That's the left side. Another way of thinking about this is what goes over the right main stem bronchus? Well, it's not the artery. We said that the artery is below the right main stem bronchus, right? We said that the airway is eparterial or above the pulmonary artery. So what goes over the right main stem bronchus? Well, the right main stem bronchus, the structure that goes over it, is your azygous vein. And the way I remember that is that veins are on the right and arteries are on the left. So on the left side, the main pulmonary artery goes over the left main stem bronchus. So the left main pulmonary artery over the left main stem bronchus. On the right side, what goes over that? It's going to be a vein, and it's your azygous vein. Your azygous vein goes over your right main stem bronchus. So the left main stem bronchus is hip arterial. The right main stem bronchus is eparterial. Important anatomy for you to remember and how this corresponds to what we see on the lateral radiograph. Here's a schematic of what we just saw. We can see the main pulmonary artery coming straight up and going back and then dividing into your left and right main pulmonary arteries. So how do these structures now look on the lateral view? So remember, your right ventricle is anteriorly located, therefore the beginning of your main pulmonary artery has to be anteriorly located, and it's going to go from anterior to posterior. So this represents your main pulmonary artery. Your main pulmonary artery then is going to divide into both the right and left main pulmonary arteries. However, we don't really see those well on the lateral view. The right main pulmonary artery, remember, is going to sit in front of the airways. So it's going to sit in front of the airways, so in front of and below the right upper lobe bronchus, the smaller circle. So we can see that here. So this is what's known as the right vascular opacity, and that's because this is composed of both artery and vein overlapping. And then here's the airways, and you can see that it's sitting below the major airways. Whereas your left main pulmonary artery actually goes over the left main stem bronchus. So you can see that here. This is your left main pulmonary artery. And notice how it's going over the airway. So now how do each of these structures represent a cardiac contour on frontal and lateral radiographs of the chest? So let's start with the right heart border. So the right heart border, remember, is going to be formed by the right atrium. And then we have this border just above the right atrium. That's not going to be the SVC, even though the SVC goes into the right atrium. Remember, this is the portion of the aorta, the ascending aorta, that's swinging from right to left. So this represents your ascending aorta. And then we have our aortic knob, which represents the aorta running from anterior to posterior. That forms one mogul. The next bump that we see here is actually your main pulmonary artery. That's the portion of the main pulmonary arterial trunk that comes up and eventually will divide into your left and right main pulmonary arteries. Then the next bump that we see here, so the third mogul as we come down, this is going to be our left atrial appendage. And then finally, the majority of the left heart border is going to be formed by the left ventricle. So these are the major cardiomediastinal contours that you need to know. If we subtract that out, we get left with an outline of the heart, and you should be able to label each of these cardiac contours. So what forms cardiomediastinal contours on the lateral view? So let's start posteriorly. So the most posterior and superior aspect of the heart on the lateral view, so up here, is going to represent the left atrium. Remember, that's the most posterior and superior. The inferior and posterior aspect of the heart is going to be formed by the left ventricle, and sometimes you could actually see the IVC reflection going into the left ventricle. Anteriorly, we have our right ventricle. Remember, the right ventricle is going to be the most anterior structure in the heart, and it also gives rise to the right ventricular outflow tract, which you can partially see. We could kind of make out our ascending aorta, though this could be kind of difficult. It helps when the aorta is calcified, as we typically see in some older patients. But it's pretty easy to make out the aortic arch, as well as the proximal aspects of the descending aorta. Now notice in front of and behind the airways, we have these two contours. The one more anteriorly located, that's going to be our right vascular opacity. The one that's more posteriorly located is our left pulmonary artery. So we have vessels both in front of and behind and going over the left main stem airway, which is the lower, larger circle. But notice, and it's important to remember this, there's nothing underneath the airway. That's a clear space that we'll be talking about in the upcoming slides. This is a representation of everything on the previous slides that we just saw. So we can see that the right heart border is formed by the right atrium. We can see how the ascending aorta swings out laterally, forming that ascending contour. Then we have the aortic knob, main pulmonary artery, left atrial appendage, and left ventricle. So let's move on to structures outside the Cornea Mediastinum. So these two structures outlined here are obviously both diaphragms, so the left and right hemidiaphragms. Normally these should be nice and convex up, and then coming down to nice, sharp, clean angles. These are what are known as the Costophrenic Angle. So costo is going to be rib, phrenic in relation to the diaphragm. So costophrenic, these are your lateral costophrenic angles. More medially, we have the cardiophrenic angles. So cardio heart, phrenic diaphragm, so cardiophrenic angles. On the lateral view, again, we can see both the right and left hemidiaphragms. The question always becomes is which one is which? So the right hemidiaphragm will typically extend all the way anteriorly, and that's because it's not going to be obscured by the heart. Whereas the left hemidiaphragm, represented here in red, the front portions of it are typically not well seen because the heart is sitting on top of it. In addition, because the lateral radiograph is taken with the left side being closer to the plate and the right side being further from the plate, the right hemidiaphragm will often appear larger and project more posteriorly than the left hemidiaphragm due to magnification. Back here we have our posterior costophrenic angles. The posterior costophrenic angles are a more sensitive place to find pleural effusions. So what about our hilar structures? So the hilar structures that we see on the frontal radiograph are mainly composed of the pulmonary arteries. So in here we have the short main pulmonary arteries, so right and left main pulmonary arteries. These will give off a more medially located branch in the right upper lobe and left upper lobe pulmonary arteries. The right upper lobe pulmonary artery is also known as the truncus anterior. And then the branches that supply the lingular and lower lobes and right middle and lower lobe are the intralobar pulmonary arteries. So these are all arteries that are sitting in here. A typical size for the intralobar pulmonary artery is around 17 millimeters. So now let's talk about lung anatomy. So let's talk about the right lung first. The right lung has 3 lobes. The lobes are then divided by 2 fissures. So the 2 fissures are going to be the right minor fissure, which we can see in the frontal view, and then also the right major fissure, which we cannot see in the frontal view, and that's because it has a more oblique course. These are going to divide the lung into 3 lobes. So the right upper lobe is going to be superior and anterior to the major and minor fissures. The right middle lobe is going to be inferior to the minor fissure and anterior to the major fissure. And then the right lower lobe is going to be located posterior. So how do these correspond on the radiographs? So the right lower lobe, like we said on the lateral view, is going to be posteriorly located. Note how much contact the right lower lobe has with the diaphragm. So the right lower lobe has a large amount of contact with the diaphragm. And then it's going to basically extend from the diaphragm up into like the upper quarter of the chest. So it actually extends above the minor fissure. The right middle lobe, on the other hand, is going to be confined by the minor fissure. So it's always going to be below the minor fissure. And it does look like it touches the diaphragm on the frontal view, but if you look at it on the lateral view, it doesn't really contact the diaphragm. It just projects near the diaphragm on the frontal view. The right middle lobe has a large amount of contact with the right heart border. The right lower lobe is the lung that contacts the diaphragm. And this becomes really important when you're looking for the silhouette sign. Lastly, we have our right upper lobe. So our right upper lobe is going to be bounded inferiorly by the minor fissure and posteriorly by the major fissure. It's going to be the more anteriorly located portion of the lung superiorly. Now when we put these all together, on the lateral view they obviously don't overlap, but on the frontal view you can see that there's a decent amount of overlap. And this is important when trying to localize an abnormality. So say we have a pulmonary nodule represented here in this red circle. We don't know on the frontal view if that's in the right upper lobe or the superior segment of the right lower lobe. We have to localize it on the lateral view. So you could see that it could be in the right upper lobe, but it could also be within the right lower lobe if it was located more posteriorly. So let's take a look at the left side now. So the left side has a single fissure known as the major fissure or oblique fissure. You're not going to see this in the frontal view because of its predominantly oblique course. This is going to divide the lung into the left upper lobe, which is going to be anterior to it, and the left lower lobe, which is going to be posterior to it. So let's take a look at our left upper lobe. So our left upper lobe is going to go from the lung apex to almost contacting the diaphragm on the frontal view. And despite it looking like it actually contacts the diaphragm, you can see in the lateral view how it only touches a small portion of it. This is important to remember because if we do see an opacity down there that's obscuring the diaphragm, it cannot be within the left upper lobe. The left lower lobe also extends throughout much of the left hemithorax. You can see that it touches the entirety of the left hemidiaphragm and extends almost up into the lung apex. Therefore, if we do see something obscuring the diaphragm in the frontal view, we should consider it to be within the left lower lobe. In addition, it's also important to remember that if we look at the frontal view, we can see that the left lower lobe extends below the upper contour of the diaphragm. And that's because the diaphragms have a sloping inferior course. So sometimes you could see nodules that project over the diaphragm that are actually within the very posterior and inferior aspects of the left lower lobe. So you can imagine when these two lobes are superimposed on each other, there's a large amount of overlap. This is important to remember again if we see a pulmonary nodule that looks like it's in the left upper lobe on the frontal view. However, on the lateral view, it could still be in the superior segment of the left lower lobe. Again, we need that lateral view to help us confirm that nodule's location because it could easily have been within the left upper lobe as well. So let's talk about some lines and stripes in the chest radiograph. One of the ones that I always look at is the right paratracheal stripe. This is where the lung contacts the right lateral border of the trachea. This is typically really thin, less than 4 millimeters. Processes that can thicken this include lymphadenopathy, as well as blood and fluid, so mediastinal hematoma, or in the setting of interstitial pulmonary edema. Another line that I like to look at, or space that I like to look at, is the AP windows. The AP window, aortopulmonary window, is between the aorta and pulmonary artery. This should be concave at all times. If this starts to take a convex shape, that is sticking out, or there's an extra contour in there, that generally means that there's lymphadenopathy or a mediastinal mass. Another line that I like to look at is my descending aortic stripe. This again, it represents the interface of the lung contacting the descending aorta. This should be nice and straight and attached to the spine or near the spine. People that have aortic aneurysms, this line may be bowed outward. In addition, posterior mediastinal processes or processes within the lung may obscure this line. We also have paraspinal lines. These lines are actually not true lines. They represent a Mach effect. Things that can widen these lines include any process that can occupy the posterior mediastinum. So if you have discitis osteomyelitis and a paravertebral abscess, that can widen those lines. If you have a fracture in the spine and a hematoma, that can widen those lines. Posterior mediastinal masses include neurogenic tumors, as well as esophageal masses and lymphadenopathy. These are what are known as the paraspinal lines. Lastly, we have something known as the Azaghal esophageal recess. This line runs from superior to inferiorly, right to left, and is concave facing the left lung. If you see that this line is being pushed to the right, that generally means that there's something within that region, such as left atrial enlargement, a bronchogenic cyst, or even a very large hiatal hernia. Two additional lines that you may see on the frontal radiograph are the junction lines. There's the posterior junction line, which is more superiorly located, and the anterior junction line, which is more inferiorly located. These represent areas where the lungs contact each other both posteriorly and anteriorly. Another way of thinking about these lines is that they represent 4 layers of pleura. That is visceral and parietal pleura on the right and visceral and parietal pleura on the left, both contacting each other. The posterior junction line is always going to be more superiorly located than the anterior junction line and will extend above the clavicle heads. This is because the clavicles are the most anteriorly located structure in the chest, and therefore the posterior aspects of the lung will extend above the clavicles. Another way that I remember this is that they're best seen in a PA view of the chest. So PA, posterior over anterior. So posterior always over anterior being the more superiorly located line. So what about some clear spaces? So clear spaces we see on the lateral radiograph. One of the important ones to look at is the retrosternal clear space. This is the dark area just behind the sternum. The retrosternal clear space can either be obliterated or it could be hyperexpanded. It could be hyperexpanded in the setting of emphysema or obliterated in the setting of an anterior mediastinal mass or a really dilated main pulmonary artery which can push up into the retrosternal clear space. Rader's triangle is demarcated by the posterior wall of the trachea, inferiorly by the aortic arch, and posteriorly by the spine. This is known as Rader's triangle, also known as the retrotracheal clear space. So what lives back here? You could have aberrant vessels, like an aberrant subclavian artery. You could have esophageal abnormalities, such as a mass. You could also have a posteriorly located thyroid goiter extending down from the neck. Those are the predominant abnormalities you should think about in the mediastinum within Rader's triangle, also known as the retrotracheal clear space. Another important place to look at is the infrahilar window. The infrahilar window is a clear space just below the left main stem bronchus, the left main stem bronchus being the lower of the 2 lucent circles on the radiograph. That space should be completely clear. Remember, in front of the airway, you should have the right vascular opacity. Over and behind the airway, you should have the left pulmonary artery. In no way should you have anything underneath the left main stem airway. If you have filling in of this space, that generally means that there's a mass within the hilum or that there's hilar adenopathy. This is again known as the infrahilar window. You have your retrocardiac clear space. The retrocardiac clear space generally should be a clear area just behind the heart. Sometimes this area can be filled with an esophageal hiatal hernia or an opacity within the lungs that's projecting within it that may be difficult to see on a frontal view. So again, these are all your clear spaces, and it's a good approach to looking at each of these clear spaces on the lateral view. If you guys have any questions regarding this anatomy, please feel free to reach out to me via email. Thanks.